It's been a rough night. Complex, sick patients at every turn. You grab the next chart in the rack, and you're relieved. Finally, something simple. A basic laceration. But wait, the laceration happened yesterday. Is it too late to close it? Is the infection rate too high? Although the details vary, classic teaching in emergency medicine is that after a certain point in time, it's too risky to suture lacerations closed. We're told that the risk of infection goes up dramatically after 6, or is it 8, or maybe 12 hours. Therefore, these late presenters should just be left alone to heal by secondary intent. Or through a delayed primary closure, although I've never actually seen that done in real life. This recommendation never made any physiologic sense to me. Like, why exactly would time matter, right? Contamination is contamination. Bacteria will multiply whether the skin is open or closed. Bacteria are microscopic. I guarantee you they're not being trapped in the wound with just a few sutures, right? And even if they were, they're there already. They were present when the patient presented to the emergency department at 1 hour. So how does time really change anything? If anything, closing the wound creates this nice, warm, moist environment for bacterial growth. Now, of course, our primary protection against infection is the immune system, but that's functioning in either scenario. And more importantly, what's our alternative if the patient does present late, right? We're told to leave the wound open. But why would leaving a wound open decrease infection? If anything, because of increased exposure to contaminants, it seems like those ones would be the ones more likely to become infected. Now, apparently the idea of a golden period for laceration repair dates way back to the work of a Paul Leopold Friedrich back in 1898. Now, I haven't been able to find the original publication, which I think would be fascinating, but it's probably futile because I can't read German. But basically, he cut open guinea pigs, artificially contaminated the wounds with bacteria, and then cut out the entire wound, which I guess is like debridement on steroids. And if the excision happened after 6 hours, all of the guinea pigs died, and that's where the idea of a golden period came from, but obviously not all that relevant to our modern emergency department patients. Now, I've seen the concept of a golden period for laceration repair from many different sources, textbooks, guidelines, different reviews, but unfortunately, there's almost never a citation to support that claim. And when there is, it just leads to another secondary source or a paper that's completely irrelevant. And this is a classic problem with many textbooks and many guidelines. They sound definitive, but they often provide no method to determine whether their recommendations are actually science-based. So I have 2 questions that I would love to have evidence for. First, does the infection rate for lacerations actually go up over time? Don't know. Second, if late presenters are at higher risk of infection, how does that actually change management? Is wound closure actually a bad idea? Now, unfortunately, after spending a lot of time with the literature, I got to say the evidence is going to be poor for both questions, maybe even non-existent. Now, there's a 2012 systematic review that found 4 single-center, very small trials comparing primary early closure to late primary closure, a very low-quality data, but 3 of the 4 were statistically negative. The 4th showed a relative risk for infection of 4.8 in a group of patients who had their wound closed late. There were a couple bigger studies looking at emergency department wounds that answer a lot of different questions, but they do include the question of late closure. So Quinn 2014 had 2,600 patients, or a little bit more, and the infection rate for those presenting before 6 hours was exactly the same as those presenting after 6 hours, 3 versus 3.7%. Hollander 2001 is a very large observational data set, 5,000 emergency patients, and the average time from injury for patients who had an infection was 3.3 hours. For those who didn't have an infection was 2.6 hours, and that's not statistically different. That's really all we have. Similar studies to that. Not good data, and it is rife with confounders, right? People rarely choose to delay their care if they have other options. And furthermore, if somebody does present late, clinicians often treat them differently, biasing this observational data. So there's a ton of uncertainty here. There really isn't any good evidence that delayed presentation actually significantly increases the risk of infection. But if I had to guess, there probably is a slight increase looking at this data. But it's not like you're jumping to 100%. We're talking about a small absolute increase. So we've probably been overestimating the risk. It probably isn't big enough to overwhelm the benefit of closure because, of course, this isn't one-sided. You have to consider both the benefits and the harms. That being said, I don't think any of this data actually matters because these trials are asking the wrong question. It doesn't matter if delayed wounds have a higher infection rate than early wounds because it's not like we're asking patients to wait before we repair their lacerations. Unless you work in a system with like 12-hour wait times in the emergency department, that's a different issue. The question only arises when the patient, for whatever reason, already arrived late. At that point, it doesn't matter if their infection rate would have been lower if they had presented 6 hours ago. We don't have time machines. At least I don't. You would tell me if you had a time machine, right? Without access to a time machine, the question that we need to ask, given that the patient has already presented late, is what is the ideal management now? Does suturing increase the rate of infection in this population? And as far as I can tell, there is not a single trial that has compared primary to secondary intent healing in patients with lacerations who presented in a delayed time frame. There were also no trials comparing primary closure to delayed primary closure. There's a Cochrane review in 2013 who looked for this data, and they didn't find any trials that fit their inclusion criteria. Now, there's a little bit of surgical literature that suggests early closure of a contaminated wound is better than delayed, and it'll be in the link in the blog post, but it has some problems that make it less relevant for our patients, so I'm not going to go through it in detail in the video here. We just don't know. And that's science for you. Science is messy. Science is often lacking. This is also a great demonstration of classic medical education, right? People make very strong assertions which turn out to have no scientific basis at all. Scientifically, the answer here is very easy. We don't know. We just don't know. Scientifically, the answer is we really need an RCT. Take every patient presenting after 6 hours or after 12 hours, whatever number you want, and randomize them to closure or not. But that doesn't help most of us right now, right? We want an answer now, a clinical answer now. So personally, I look at this data and I think about basic biology. And for the most part, time since injury is just not a big factor in my decision about whether or not to close a wound. I don't know if it's true, but I just assume that a late presentation probably increases the risk of infection a little bit. And assuming that the rate of infection is a little bit higher, I ask myself, what's the best way to manage this wound, considering that there's probably an increased risk of infection? It's the same judgment call that I make with all wounds. If this wound is caked in mud or contaminated in some other way, what do you do with a wound that is more likely to get infected? So I'll probably spend more time cleaning this wound out. I might do some debriding. I adjust my aftercare instructions. I don't think prophylactic antibiotics make any sense, and we'll get to that in more detail in future videos, but just think about it. Giving 100 patients antibiotics today to prevent 5 people from needing antibiotics in 3 days makes absolutely no sense at all. Now, if the patient is super high risk for infection, or if the infection is in a very sensitive area, I might adjust my closure so that it's less likely to, seal an abscess in, or to make it easier for the next doctor who might have to remove a few of my sutures. Although that being said, as you'll find out in a future video in this series, I almost never use sutures anymore. But for the most part, look, time from injury just doesn't impact my management in the emergency department. I just inform the patient that they might have a slightly higher risk of infection because of the delay, but I repair the laceration exactly like I always do and just ask the patient to monitor closely for signs of infection. That's it for this episode. I have a bunch of episodes planned on the evidence behind laceration repair. We might be doing laceration repair for a very long time. We got irrigation, how and why, sterile gloves, management of dog bites, glue versus sutures versus absorbable sutures, aftercare instructions. We might be on this for months. I'll probably space them out. But if you have specific questions you'd like answered as part of this series, please leave them in the comments below. And as always, there's tons more information and resources at first10em.com. Until next time, take care.